We worked all summer getting lots and lots of input to our consultant, the Stevens Group. They thought through, did lots and lots of analysis through the summer and into the fall, interacting with lots of us in the audience, here on the task force and other places. On October 7th, they walked us through their recommendation package to the task force. Shortly after that, the governor sent out a letter with his point of view on how he would see implementing the recommendation package. Since then, we have been discussing amongst ourselves and in other ways and with other people and getting responses. And basically that process is going to continue today. Most of the items on our agenda deal with questions and answers about that report, points of view about different aspects of the report, and that process is going to continue through today. So with that, I'll turn it over to my co-chair for any comments she has, and then we'll work to get the meeting minutes approved.
Thank you, Mr. Chair. I just want to welcome everybody here, and I think we're all ready to go to work. Thank you.
Okay, can I get a motion to adopt the October 20 meeting minutes? We got Justin Boyd with the motion and Senator Cooper with a second. All in favor? Aye. Any opposed? The minutes are approved. Next, we're going to have our consultant, John Steven. If you want to come up to the chair, John, and your team is welcome to come up. And John and his team are going to respond to task force meeting questions from the October 20th meeting, and also a little bit of an update from Montana's CMS waiver approval. John, if you and your team would go ahead and introduce yourself, and then you're recognized as needed from there.
Thank you, Mr. Chair. My name is John Steven, for the record, managing partner of the Steven Group.
My name is Stephen Palmer, senior consultant with the Steven Group.
Richard Kellogg, senior consultant with the Steven Group.
Thank you. Mr. Chair, we'll go as quickly as possible. What we wanted to do is update from the last meeting. There were a number of questions and tasks that we were assigned, and we wanted to make sure you, at least to give you an update where we are on these assignments. The first one, I see Representative Boyd here, and Rory could not make it today, but he's been doing the work in terms of the vaccine issue. So I just want to raise this. You're going to see this Medicaid vaccine spreadsheet that Representative Boyd shared with us. We've had our pharmacy expert speak to the department, and there's an ongoing dialogue happening right now with regard to what exactly is in the vaccine reimbursement numbers and how they're broken out. Rory has kept in touch with Representative Boyd, and there's a few things he wanted to report. And I think what's really important here for the committee is to, as we go forward, if we look at more of a global vision of some of our thoughts, and also what the governor had talked about in terms of really improving population health, there is an issue here that Representative Boyd brought up, that he has a really good issue about vaccines and the reimbursement. So it doesn't appear that there is a high administrative cost in Arkansas to administer the vaccine, and this is prevention-related focus. And if you look at the chart, you will see on the right-hand column administrative fees paid, and it's for adults in the vaccine program, it appears to be no administrative fee at all. So the doctor administering the vaccine is not being paid, it appears here, for actually doing the administration. We have subsequently checked with the department, and there is an administrative fee that Medicaid pays. So that right-hand column of zeros is not correct. It is, according to DHS, it is subsumed within that rate that you see on the left-hand side product column. It's a very small amount to administer, though. And when you look at these drugs and compare them, there's still not a lot. You're not covering your cost in many of these vaccines. So it is an issue that was raised to us. Rory feels it's a multifaceted problem. It's not a simple solution here. Improving vaccine rates among individuals is also consistent with public health and will likely lower population health costs. So it's important that we really get to the bottom of this to determine what you feel should be an appropriate response with regard to vaccines. We're collecting data at DHS, Department of Health, the private option carriers, CDC, and other states. We plan to analyze those findings, and we're going to benchmark them against other states because we want to find out what other states do as well. So basically, that's kind of where we are today, and I can tell you that, again, Representative Boyd has uncovered an issue that I think you need to look at. From our own experience, it appears that the rates to administer vaccines for adult population, not children, are very, very low. And the question is, in our minds, where is this population going to get their vaccines? Are they showing up at the Department of Health? Are they showing up where there's some free clinics? Or are they not getting the vaccine at the PCP? Is the PCP eating the cost? There's a number of issues here. So I just want you all to know that was one of the issues that was raised by Representative Boyd. We are still doing some work so we can come back and give you full financial and other state analysis on the issue of vaccines in the administration. So that's the first issue. If anyone had any questions, Representative. Mr. Chair. Okay? The next issue is the designated related groups, the diagnosis-related groups, actually. DRGs, we heard a lot about in our recommendation. We heard from Bob Chin and Stephen Palmer. Stephen's here. I'm going to have him walk through just to give you an understanding of what DRG is all about. Again, real brief, high level, but knowing that there's going to be an item on the agenda here for Representative Farrar to talk about the DRG study group. So we're going to go through this real quick.
So one of the issues that came up at the last meeting was the question of diagnosis-related groups for reimbursement for hospital inpatient services. The request was made to go into a little more detail about diagnosis-related groups and what they are, how they're used. So that's what these next several slides and next several minutes will be about. So diagnosis-related groups, or DRGs, are a patient classification scheme that's used by payers for connecting patients to certain levels of resource costs borne by hospitals. The whole purpose of DRGs is to be able to classify patients into certain resource buckets for the purpose that are similar across different clinical and risk type groups based on their typical consumption of hospital resources. There are several different types of DRGs. The most common are the DRGs used by Medicare, which are referred to as Medicare Severity Diagnosis-Related Groups, or MSDRGs. And then the All-Patient Refined Diagnosis-Related Group, or APR-DRG, is increasingly becoming the most common type of hospital inpatient payment structure. Both of these DRGs code sets and classification schemes were developed by 3M, the first under contract with CMS for Medicare program, the second in partnership with the National Association of Children's Hospitals. As the primary purpose of the APR-DRG was to expand the DRG strategy and approach to a population that encompassed all different types of patients. As you all know, the Medicare population is very different from the Medicaid population. In developing the APR-DRG mechanism, it included a number of additional pediatric and obstetric procedures that are not included in the MSDRG structure, and it included additional acuity levels and logic for including comorbidities. At this point, the majority of state Medicaid programs use APR-DRGs for inpatient hospital payment. A number of other payers use this as well, at least in part, including the Arkansas Blue Cross Blue Shield and other payers, private payers here in Arkansas. And more than half of the hospitals in Arkansas are already licensing the APR-DRG software for their own internal financial analysis purposes. So in practice, the way the DRG approach works is that there's a multiplier associated with each DRG that is multiplied by some base rate, and that base rate is meant to be the base resource utilization cost for the hospital for a typical base case. And then different base rates can be established based on different hospital types, for instance, children's hospitals versus non, or rural hospitals versus urban hospitals, or other hospital characteristics, such as teaching hospitals or hospitals that have particularly high levels of uninsured patients. So that's the overview of the diagnosis-related group structure and approach. Representative Ferreira will be talking about the work group in a few minutes, but I'd be happy to take any questions if there are any.
Okay. The other question was Representative Gray had asked about when we had done our recommendations on savings estimates, did we look at historical nursing home census population to determine rebalancing savings? Representative Gray's question was a very good question, because when you look back at historical, and we did say we didn't use the historical, we based our savings estimates off of the 2014 number. And it's in our report. It's somewhere around, at the time we looked at the data, it was around 11,400 in the nursing home. So what you look at the historical rate, and you do see some reduction in the numbers, but it's not significant in terms of a reduction in the numbers. And what we did in determining our savings estimates was really try to get a 50-50% split in terms of census, or savings actually, dollars, so that we look at the number of people that are in nursing home going down somewhere around 9,000 over the span of that 2017 to 2021 period, 9,000 plus, I forget exactly the amount. But what I want to show you here is the historical numbers so that you can see it is in fact going down. The census has been going down, but it's been going down at a low rate, which is it's not bad. The fact is there is some capacity that's being put into the community, but not at an aggressive level. So if you look at the next slide, you could see if we just focus on private nursing home, 2007, the census was 12,303. That's the average census for the year. 2015, it looks like it's going to be about 11,218, so it is coming down. There is more capacity in the community, but it's, again, not at a real aggressive pace like we think that you could be at to follow the model of other states. But again, you get to see that from that time period, I believe the change was about 7% over that entire period, a 7% reduction. Again, if you look at the whole period, it's about 1% plus a year. Again, not real significant, but it is important to look at in terms of historical numbers. They're not going way up. Then you look at this next slide, and this is beneficiaries by type indexed, and you can see that the private nursing home crossover amounts are going up rather significantly. That's shorter term stay, but again, very stagnant in terms of total growth. And then what we have done in our rebalancing, again, savings estimates, were to really look at reducing that number, but also increasing substantially the home and community-based number, which could also involve assisted living, so that you come, instead of a 60-40 split, you come where some in around 2018, 19, 20 years, you start to come to a 50-50 split. And those savings that we generated are real, and they're not going to be that much impacted from this historical baseline. But if we did use a historical baseline, the savings may have gone down a little, but you got to remember that the number of these increases in home and community base would have come down instead of gone up higher. So it would kind of marginally work its way out. So our recommendation savings, we still stand firm on, that are an estimate. Again, it's an estimate. So we're just giving you a ballpark. And that's what I wanted to make sure we clarified, and Representative Gray was absolutely correct in the historical picture here. So that's what we wanted to show you.
Representative Gray, you're recognized for a question.
Thank you, Mr. Chair. Thank you very much for providing this data. It's actually better than what thought it was going to be. And the reason I had asked for the historical data was because in your savings model, in part of your, when you go to like managed care or whatever, in your savings model, you predicted your savings based on a 30% growth over 5 years. So my point was, it is very unrealistic to base a savings model on 30% growth when over the past 8 years, they've actually experienced a 1% decline, if that makes sense. So I just want to understand how you can predict savings based on 30% growth when there's been a decline in growth historically over 8 years.
Yeah, I'm going to let Stephen address that.
And in the projections that we had made on the population basis, we had used a 3% annual that compounded up to a larger amount over the 5 years, of course. But the 3% annual population growth was based on the U.S. Census Bureau's projections of the growth in the over 65 population. And as you know, we're starting to experience the sort of the largest bulge in the baby boom population hitting that retirement age. And so basing the next 5 years on the past 5 years experience didn't seem like the most reasonable approach.
Well, and that's, pardon me, Chair, but in my experience, the best way to predict the future is by looking at the past. And so I question I could understand if maybe over a couple-year period, we were looking at a 5% growth model, but we're looking at a 30% growth model when we've experienced a 1% decline in 8 years. So I just question I would like to actually see the amount of savings that you projected for that nursing home population by implementing managed care with that 30% growth. So I guess my point would be, in your 3 recommendations, we've got $700 million, $1.2 billion, and I think $2 billion based on the different models we go with. I would like to know what percentage of that savings that you quantified to nursing homes, because 30% is an unrealistic growth factor for 5 years based on this. So that's what I would like to see, is that number broken out separately from that savings model on each one of the 3 models. Is that something that I could get?
Yeah, and we might need your help in finding that 30% number, because
Okay.
our annual increase was 3%, which compounds to something over 15%, but I don't think it would
Okay.
be.
Well, and that's not what was, I'll find it for you. That's not what was in
Thank
the
you.
report. Thank you.
Senator Cooper, you're recognized for a question.
Mr. Chair, on the population in nursing homes, the occupancy, is this bed days per year? Is this calculated by individual? And if so, how does the length of stay compare today to what it was, say, 5 years ago? And is that taken into consideration when you calculate this? You follow what I'm asking?
I'm not sure.
Okay, let me elaborate a little bit. Probably today, now this is just my feeling about it, that there is more rehabilitation done today than there was several years ago. And that should result in people coming into the nursing home being rehabilitated and leaving the nursing home, whereas a few years ago, more people would come in and stay. Now, that will result in fewer individual bed days in the nursing home, but the number of people there might be relatively the same.
So there are a couple of different moving parts to that within that question. Generally, the data that we have captured here is not on total nursing home census, but rather on Medicaid paid nursing home days or nursing home residents. Typically, the rehab stays are picked up by Medicare, because these are going to be individuals that may be dually eligible for Medicare and Medicaid. Medicare will pick up the first part of that nursing home stay, and if they require long-term services, then it will flip over to Medicaid. But generally, the nursing home stays that are paid by or that are for post-acute rehabilitation are going to be picked up by Medicare. And so those numbers will not be in our figures. That having been said, we have not captured any churn on the, the purely Medicaid side, and there may be some, and we can look into that with the agency.
So you're saying that that's not in your calculation then? Is that what you're saying?
Medicare paid days are not included in our projections. Only Medicaid nursing home days are in the projection, in the numbers that you see here.
So when you project the growth or decline in nursing home population, are you saying those accurate numbers, or are you saying they're not?
Well, we believe that they're reasonable numbers, but, you know, predicting the future is difficult.
Well, what I'm hearing you saying, I'm not sure that we can rely on that number.
We believe that the numbers that we have for the Medicaid population and the Medicaid spend on nursing homes are reasonable.
Okay. Thank you, Mr. Chair.
So if I was just to play back what I think I'm hearing a little bit, if there was a fixed number of people and in a period of time, more and more of them went to rehabilitation that was paid for by Medicare, what you might see is a relatively constant total spend in that scenario, but you would see a shift from the nursing home dollars showing up on the Medicaid side of the ledger, that would go down, and the Medicare side of the ledger would go up. So, for example, Senator Cooper's theory could be one of the reasons why the Medicaid nursing home dollars over the past 8 years have been declining 1% instead of growing, even though aged population is growing. So in other words, your dollars are capturing the accurate trend, and that the dollars you've got in here are pretty accurately trending what's happening, even though you've got multiple things going on, more aged people, rehabilitation, Medicare picking up dollars, et cetera, and that the numbers here are actually accurate. Now, where they go in the future is a prediction, but what you've got here is accurate.
The historical here is absolutely accurate in terms of the Medicaid side. The projections, we believe, are also accurate in terms of the future Medicaid spend.
Got it. Thank you. Representative Bentley, you're recognized for a question.
Thank you, Chair. Can you guys dig a little deeper into your cost savings on home care for this population? Recently, in my own family, I had to price out what it would cost for my aged parents to go into the nursing home, and so for full-time in the nursing home is $5,000 a month, but full-time at home care with somebody around the clock is $17,000 a month. So I'm concerned about where we're going to get the cost savings by moving these folks back home with that population. Thank you.
That's a really good question. But if you look at it on an individual case, what you said is correct. There's some anomalies there, because there's a number of the folks on community-based care in your Medicaid budget that are only getting a couple thousand a year. So what we're looking at is the total population. When you move to a really enhanced community-based structure, it's a rebalancing those costs. So yes, you're right, there are going to be some costs in cases that are going to be really high, and there are going to be some that, if you see in the personal care area, especially here, which some of the folks on community base, if you do it the right way, you're going to be able to stay longer in personal care, getting a couple $1,000s a year. Folks today that could even be in the nursing home because there's no other place for them to go. And then you've got a ramp up, and then you get to assisted living, maybe it'll be a little more in terms of price, and that's where the rates change a lot. But if you need 24/7, if someone is in a nursing home needing 24/7 nursing home care, and that same person is getting the same level of care at home, it could be very much more expensive at home. So, I mean, we could compare that if you'd like, but it's not going to be the same as looking at the whole population, because we're averaging our costs. When we do savings, it's based on average of the whole population. And I want to just say one other thing on these nursing numbers, the estimates. Again, if you get to the 9,000 plus number that we said in the next few years, and I know the nursing home administrators have come in, and one, in fact, has told you about wanting to be a part of that whole rebalancing structure. And you've got to be ready for those costs to go up on the home and community-based side. So that average is very important. So what you should always keep a focus on is what is the average cost of home and community-based care in general, overall. And that's what we had put in our report. And we have all that data in those costs outlined clearly in the report. And then
Can I
what
ask-
is the
okay.
average on the nursing home?
Can I ask one more quick question? Has any other state or have you done, and in nursing homes, we have different level of care, of course. We have those that require 24/7, some that are Alzheimer's patients, they're just really needing someone to assist them. So have we looked at offering a different cost, maybe $250 a head per person less, or $5 a head on different levels of care? And have we looked at savings in that area?
The state has actually done that, has moved forward, and that was part of that whole PCMH health home model. They were looking at acuity-based, different tiered payments, and those discussions stopped, and they have not continued. And there's a lot of discussion now to either revisit those, or whether you decide, whatever you decide, managed care versus PCMH. I believe strongly, especially talking to the department and the nursing home folks, that those discussions are going to continue very soon.
Thank you.
The next, Representative Gray had a couple questions on private
Hey,
option.
John, we still got some more questions. I'm sorry. Representative Farrar, you're recognized for a question.
Thank you, Mr. Chair. Stephen, you said a little while ago that your figures on the nursing home is based on a 5% growth due to the baby boomers at 65 coming in?
Oh, it was 3%, 3%
Yes,
annual.
okay. What is the average age of a patient going into a nursing home now?
I haven't seen that information for the Medicaid population.
Okay, so no? Okay, so I guess that's one question, is the figure's right, because if the age is 80, then your 5% growth wouldn't catch up until the baby boomers reach 80.
Yeah. So now there is one of the eligibility criteria is age, and so they, under some of the eligibility groups that can get the patients into the nursing home, 65 is a threshold age on the eligibility side. So there will be a population that's just sub-65 that will become eligible by virtue of reaching 65.
Okay, just to be the eligible is what, so your numbers are just based on eligibility, not actual the age of the people in the nursing home?
Well, what we assumed was that the over 65, so that 3% growth is 3% growth in the whole over 65 population annual over the next decade, projected. So our assumption there did not incorporate, or did not require incorporating people just crossing that eligibility threshold.
Okay, all right, thank you.
We can ask and find out, if you'd like, the average age. I think that's a good question.
Well, yeah, like I said, if you're predicting the growth based on 65, and that's what I kind of, maybe I misunderstood, but if in the average age of going to a nursing home was 80, then the average, your figures may be off by a couple of years or so, 15, 20 years. So, thank you.
Again, it's a reasonable way of projecting these costs, because you're dealing with, I mean, when we looked at this as a team, we had a lot of discussions, Representative, on what rate we're going to use. And we saw Arkansas had, for the data we looked at nationally, Arkansas's aging population was growing at a rate higher than the other states. And then we took the population growth estimates from CMS, and we looked at the age estimates on the National Census Bureau, and that's how we came up with what the cost could be going forward. The next.
Oh, I'm sorry.
Okay,
I
didn't see
got two more questions, John. Representative
sorry.
Hammer, you're recognized for a question.
Thank you, Mr. Chair. Just make sure I understand, the numbers that you're talking about, that are being talked about, strictly deal with the Medicaid population only, no consideration for the Medicare population or anybody else. Is that correct?
That's correct.
Okay, so when we talk about these numbers and the percentages of increases and, being down 400 beds, is there any consideration in there for the population that currently, because they have the financial resources to be able to do it, are opting for assisted living programs, but did you put any weight factors in there that as Medicare continues to reduce what they're paying and stripping off the wealth and the assets of that generation that's coming into play, that some of those may actually end up qualifying for Medicaid in the future because their resources have been stripped away from them?
It's a great question, but when you looked at our rebalancing savings in the recommendation report, so we saw and we predicted an increase in home and community-based care overall. We then predicted an increase in assisted living. In fact, I think I told you this last meeting, that looking at your $900 million long-term care budget just in the nursing home long-term care area, and you see about $16-17 million in assisted living, I mean, that's a problem, because that component there is many states are using for that whole rebalancing effort. So you have a lot of opportunity. So what we're projecting here in our recommendation is when you move to this focus on the continuum of care, and maybe look through your waiver of different levels of care, making sure they're in sync with where your policy and vision is, you're going to see an increase in that assisted living. And so we did account for that in all of our savings estimates. So
Okay.
I think it's a really good question, because whether you do PCMH and whether you do managed care, you're going to want to make sure you focus in the future on making those 3 stages, let's say home and community base, assisted living, and nursing home, begin to start, being more level and being that real continuum of care that you want for your seniors in the state. When you do that, you're going to have substantial savings. There's no way around that. You are, because you are high on the nursing home side.
Okay, and follow-up, Mr. Chair. In the case of like an assessment tool, where you take John Doe, and the determination is trying to be made, could this person do better in an assisted living, or could this person go to the nursing home, or, go into the actual home and everything? What is the identifier? What is the tool that currently could be in place, or are you proposing that would say, for this person, ABC, they need to be here because their needs could be provided here for now, and then transition, through a process? Is there any consideration in any of your recommendations for that?
Thank you, Representative Hammer. The assessment tool that the state is currently using is the NRAI for nursing home, for home and community-based waiver. They're still using the former form for nursing home admission, to my knowledge, which is 703, 704. Specifically to tiering need, it's important to remember that in order to be eligible for home and community-based 1915C waiver services for aged and physically disabled, you have to be facility eligible. So it's the same eligibility standards for nursing facilities and for home and community-based 1915C waiver services. So the question becomes, number 1, choice, number 2, acuity. And the NRAI, as we understand it, has been developed to, through algorithms, to develop tiers of need that equate to tiers of cost. And that is part of the second and third levels of development of the NRAI, has been discussed by DAS in relationship to that IT contract. So in terms of acuity levels, we discussed acuity levels in the nursing facilities and in home and community-based services. From the home and community-based services side, we felt, and it's in our report and it's one of our recommendations, that the use of assisted living in the Arkansas long-term care system for Medicaid recipients who are eligible for these services is limited, and is an area that could handle a higher level of acuity than home and community-based services, but a lower level of acuity and more community interaction in an assisted living facility. So that was a factor. The other factor that we talked about, but we didn't use any kind of mathematical or algorithmic perspective in relationship to the projection of cost savings was asked in previous questions for nursing facilities, is the level of acuity. Many states have moved to levels of acuity allowable in nursing homes to a higher threshold, perhaps, than Arkansas. And you could reflect that on looking at data that comes through federally required MDS forms and RUGS assessments. We understood that approximately 20% of the current nursing home facility were at lower levels of care in comparison to the higher levels of care on those MDS standards.
Okay, my last question maybe ties into that one directly. When you calculated the cost and the savings, by restructuring the way that we're dealing with this population now, did you factor in anything for the residual effects, like multiple trips to the hospital because of a patient being in one setting above another setting? Did you weight it in any, and does that attribute to any of the percentages for the savings?
It's a great question. We did, you remember when we talked about the HALO costs? All of those costs are attributed to HALO. HALO in the community is higher. It's already, we identified that in the recommendations, in the data we looked at. So no matter what you look at, the cost differences we outlined in the recommendations are substantial. But again, you know, making sure you have the capacity in the community to handle that population is critical. So there's a number of issues that we raised as well. But yes, Representative, that's already in the recommendation.
All right, thank you.
Senator Elliott, you're recognized for a question.
Thank you, Mr. Chair. This is a question I had at our last meeting that I didn't ask because it was almost 5 o'clock, and I was afraid that I would be attacked by the 6 people who were still here if I asked it at that point. So I hope this makes sense after all this time. If not, somebody can restate it and tell me what I'm trying to ask. This has nothing, Mr. Chair, to do with the nursing homes that we were just talking about. I just wanted to put this question on the table before we move into the next part. A number of weeks ago, I had a conversation with several doctors, similar to one I'd had met several years ago, about something that they call fail first. And that is, it kind of reminded me of Mr. Palmer's report. And there is a disagreement, maybe perhaps between doctors and a policy with DHS and Medicaid, about certain medicines that would be prescribed and how they would be reimbursed. And as the doctors described it to me, one of the big things I was concerned about was asthma, because that's big in the community that I represent. A doctor might think that a child is best served and needs to be served by a particular medicine, but the policy requires that a generic is prescribed. And so this child has to fail that before the doctor can actually prescribe what he or she thinks is the best thing. And as we're talking about moving forward, I just wanted to know, you don't have to tell me now if it's going to be just someplace else, but is that addressed anywhere in anything we're doing? And are other states doing things this way? I just don't know, and it seems to be a huge issue among doctors, because if they want to prescribe what they think that child actually needs at that point, they won't be reimbursed. They have to get permission before they can just do it, as I understand it.
It's, again, Rory did mention this at the last meeting on the
Okay.
pharmacy benefit management system in place. That is normal in Medicaid. It is run usually by a third-party pharmacy benefit manager if you're not in a managed care environment. You have that today in your state. You have some of that being done at UAMS. You have some of that being done with Magellan. And they're also working closely with the department. So even the department's involved with, it's off of a PDL. They have a PDL list of generics. And the prescribing docs know to follow that. And if there is a reason that they believe strongly to move beyond that, they can get approval, but they have to go through those types of steps.
And this is I mean, are we suggesting anything different from that, or are we suggesting we leave that in place?
I think what
Is
Rory
that a
was-
best practice?
It's a
or-
great question. I think Rory's going to be here at the next meeting, and I'd like
Okay.
him to address that question for you, because he does have a number of recommendations, and he's meeting on the 24th of November with the Arkansas Pharmacy Association. So it might be, and I'll make sure he gets your question, it might be really good for him to respond after he's had, because they are also responding to the recommendations. And
Yes.
so he wanted to hear their issues as well, so we can bring that back to the task force.
Oh, well, I would appreciate that, and thank you, Mr. Chair, for letting me ask that question, because I first encountered this issue, I think, in 2009, and I'm constantly hearing from docs all the time about the problems that they're having with being able to get to kids, in my case, in this case, what they think the kids actually need at the time without a lot of go-betweens, and so I would appreciate Roy giving us
And it
further
could be,
information.
it could be, you know, certain pharmaceuticals only, that it really applies more than others. The department can react to that, and they have their own authority to remove some of those issues, restrictions. So, I mean, it's something that I'd like to have Rory address with you.
Okay, thank you. Thanks, Mr. Chair.
All right, Senator Irvin, you're recognized for a question.
Thank you, Madam Chair. Just to follow up with Senator Elliott's, I support her comments, but my question, I think it goes back to the immunization issue that we've been all very familiar with. And what is preventive care and what falls into that category? And because in agreeing with Senator Elliott on that issue, a lot of times when they're in the process of failing that generic drug, it leads to more complications, it leads to more office visits, it leads to more hospitalizations and more problems. Development of bronchitis, development of pneumonia, different things like that have occurred, particularly because with those types of patients, they're in a home situation that may not, where the parent may be smoking, where they may not have good ventilation, air conditioning, heating, whatever it may be. So I think it just kind of in a little bit of bigger perspective, if you don't mind asking him to kind of look at those kind of costs associated with that type of policy, because what my fear is we try to manage and cut it on the front end, but we're not really looking at what's that doing to the back end of cost. And so, I mean, regardless of the literally pain and suffering that a lot of these children are experiencing, apart from that, there's definitely costs that we have seen associated with those types of policies. But in the bigger discussion, preventive care and what that means, and is our payment structure geared toward that, or is it not? I guess those are kind of the things that I would try to be able to look at and drill down on to see if you want to guide people into using your healthcare system more effectively, then you have to pay for those kinds of things. If you don't pay for them, they don't go do them, just like with the immunizations issue. So where are we missing the target on that?
We'll have Rory
Okay,
address
thank
that,
you.
but it's a really good question, because you have pharmacy benefit manager that could really be squeezing those costs on one end, and then yet those costs show up on another end in your budget, and
Right.
it's a hospitalization or it's something else, and they're gonna get rewarded for doing what they needed to do. But
Right.
yet the costs over here are gonna go up, and so I really understand the question. It deals with evidence-based practice, there's a lot of issues there.
Okay.
So I'd like him to respond to that.
Absolutely. Thank you very much.
Okay.
Senator Cooper, you're recognized for a question.
Thank you, Mr. Chair. Along the same line of Senator Irving and Senator Elliott, consider that change of medication is an antipsychotic medication, and you change one from something that's been working to something that's not, you may be generating a real crisis out there that's not having to do anything with finance, but you could be creating a real disaster out there. So would you include that with what you're looking into there?
Absolutely.
Thank you.
That's a national issue as well.
All right, John, go ahead and continue.
Okay, so there's a couple questions that Representative Gray had on different alternative options, wanting to know about CSR payments, and I'll let Stephen address those questions. He's been working with Representative Gray.
Thank you. So there were a couple of questions that arose about different implementation options for the private option. The specific questions that we looked into were first, whether the private option premium should be pegged at a lower actuarial value or structured as a high deductible plan. And the second was whether it would be possible to put that premium amount into some sort of health savings account like the health independence account or something similar to allow the enrollee to directly purchase a plan. On the first question of pegging the private option premium to a lower actuarial amount, just as a reminder, the private option premium is tied to the same criteria as the subsidized plans through the health insurance exchange. That is to say, they're referred to as silver plans, which generally the total value of the premium is pegged at about 70% of the actuarial value of the plan. And so that's how the PO is now, and I'm going to talk a little bit about that, which will help to explain the rest of it. In the table on this slide, we see the total actuarial value of the plan in the column up the left. Starting with the 70% at the bottom, that's the approximate actuarial value of the benefit that is paid for by the premium. Then on top of that, a payment, this is in the private option, a payment goes to the carrier from the department for what's called the cost sharing reduction. This is an additional payment that's made to cover what normally would be the co-pays and components of the deductible paid for by the individual, but under the private option, per the waiver agreement, that amount is largely paid for with this cost-sharing reduction payment. On top of that, there's an additional payment for those individuals who are above 100% of FPL, that covers approximately 2.5% of the actuarial value of the plan. And then for those underneath 100% of FPL, there's an additional 3.5%, which covers the full, up to the full 100% actuarial value of the plan. Those final three categories, the basic cost-sharing reduction and then the two deductible buy-downs, are subject to what's called the cost-sharing reduction reconciliation. This is a retrospective process through which there is a reconciliation of the actual amounts paid by the plans, the claimed amounts that the plans have to pay, and the amount that the plan received. And that results in a dollar-for-dollar reconciliation, such that the carrier is not getting any sort of windfall off of those categories of payment. For the component of it that's covered by the premium, the 70%, that's subject to a similar reconciliation known as the medical loss ratio, whereby the carriers are required to pay out a certain amount, in this case 80%, of the premium intake in terms of medical costs. That in that category, there is an allowance for some amount of administrative overhead and profit, but that medical loss ratio does require the repayment of rebates, what amount to rebates back to the state, and then some portion of that goes back to the federal government in cases where the actual medical spend is less. So if we were to, for instance, peg the PO premium to something like 60% of the actuarial value instead of 70%, which is what the bronze plans on the exchange, is how the bronze plans on the exchange are structured, that amount that's subject to the medical loss ratio reconciliation would go down, and the amount subject to the CSR reconciliation would go up. There is a possibility in that for a small amount of savings across the board, because the CSR reconciliation is a dollar-for-dollar reconciliation, whereas the MLR reconciliation allows for a certain amount of administrative overhead and profit. That having been said, the part of the reason for going with the silver plans is that's what the type of plans that the carriers were developing for use on the health insurance exchanges. And that is the type of plan that they have developed systems and processes for, including the CSR reconciliation and so on. In addition, so there would be costs on the carrier side that then might get passed through in terms of the premium costs to transitioning to a different structure for the Arkansas PO than is being used for the exchange, their exchange plans in Arkansas. In addition, the whole of the spend is subject to several other risk-sharing components. A reinsurance layer, they're referred to as the 3 Rs, reinsurance, risk corridors, and risk adjustment. These are 3 mechanisms for ensuring that no individual plan within a given market is subject to adverse selection against the plan. Those, in order to model what this would actually result in, or could potentially result in terms of cost savings, is the state shifting to a lower pegged amount. would require considering those several layers as well in additional analysis, that reinsurance, risk corridors, and risk adjustment. And then I think, yeah, that largely covers that piece of it. That's a lot of detail, so I'd be happy to answer any questions.
Representative Farrar, you recognized for a question.
Yeah, you mentioned that the MLR, we had an MLR in the state of 79%. I think that's what you said in your report. But the insurance companies are giving us a 7% rate increase. If they're going to have to pay money back because of the MLR being 79, why are we getting a 7% rate increase?
I'm not familiar with those details right now, but I can look into that and respond to that.
Okay, I'd like to know, because it doesn't really, it looks like they would be cutting rates instead of increasing them. So if you get that information, I appreciate it. Thank you.
Representative Meeks, you recognized for a question.
Thank you, Mr. Chair. My question is over a statement that you made that they developed the silver plan, for the marketplace. It's my understanding that, you have all three. You have bronze, silver, and gold. So could you dive into that a little bit more as to why, the silver plan, I guess, was the best, or why, it's not going to save us that much money?
Yeah, and you're exactly right. That carriers generally had the option of developing some set of bronze, silver, gold, or platinum plans. They didn't have to do all of them, but those were the basic categories. And they did tie to 60, 70, 80, and 90% actuarial value. For the individuals who purchase through the exchange that are eligible for subsidies, that is those over 138% but below 400%, to get the subsidies, they only could purchase the silver plans. Those were the only plans for which the subsidy was available. And so that it is that cost-sharing reduction reconciliation that also applies to those subsidized plans. And so in terms of the processes and systems that the carriers developed to incorporate the cost-sharing reduction reconciliation into their business operations, they developed it around the silver plans, not around the other plans.
Again, I'm trying to wrap my head, because you're saying that just a person, not a private option person, but just a person that wanted to go to the exchange. It's my understanding that they can get a subsidy for the bronze, the silver, or the gold. So I'm trying to understand why you have focused in and say, well, no, they went with the silver plan, so can you kind of?
Yeah, I can do a little more research on that and come back to you with some better information.
Yeah, I would like to maybe see that, and that may be something that somebody from DHS can say how many folks bought the bronze plan, those who are not on the private option, those who bought the bronze, silver, and gold plan, because, when we were working on our state teacher health insurance plan, we basically got the recommendation that in order for it to be more sustainable, we need more teachers to get off the gold plan and go down to the bronze plan. And so I would think that this would be kind of similar, that if we want to see a more sustainable plan and save some money, that maybe those folks who are healthy and don't use the system as much, if we can get them to the bronze plan, or maybe even a catastrophic type plan, that it would save money and that they would still be able to get the health care that they need.
And we can look into that. One piece of that, though, or just one point of reference as far as that goes, the reason for the cost-sharing reduction and the other supplemental payments is because CMS has generally taken a pretty strong line about not pushing a lot of the cost onto the individual for these lower income groups. Generally, for a private commercial situation, if you can shift people from a plan that covers 80% of the actuarial value of the plan, like the gold plan does, down to one that only covers 60%, you do save money on the plan sponsor side, but that is at the cost of pushing it onto the enrollees. And that's not something that CMS has historically been tolerant of.
If I could just make one more comment on that. And again, I would think, though, if we could look over the previous year and we could see that these folks are healthy, we could put them on the bronze plan, because if they're below 100%, they're not paying a copay anyways. That wraparound cost then would go to the state. And again, I think if we get those healthier folks down onto the bronze plan, we're going to save money on the premium, and we're not going to have a high wraparound cost necessarily, because of the fact that they're not going, so we're not paying the deductible for them, basically. So again, I would kind of like to maybe see something run where, hey, if we take a portion of that healthy population, move them over to the bronze plan, again, they're getting the health care that they need, but we can save the state maybe some money because we're not paying out as much in a premium.
And we can model that.
Okay, thank you. Thank you, Mr. Chair.
Senator Ervin, you're recognized for a question.
Thank you. Just follow up on Representative Meeks, the CMS issue. Would you be able to get a waiver for that or negotiate that through a waiver? Or, I mean, I understand historically, but we also didn't think Montana was going to get the 50%. So I wanted to check on that. And then are you familiar with New York? I think they did a reinsurance type of a project. The state of New York did. I had some information, I think, on that. I just wanted to see if those were options kind of along those same lines.
We can look into the New York one, and if you have some information that you'd like
Okay,
to
I'll get
point
it
us
to you.
toward, we can look into that. On the former, whether the sort of shifts to like a bronze plan or a catastrophic
Right.
plan are things that could be included in a waiver, you can try to get anything approved in a waiver.
Okay.
But we just base our sort of claims about what CMS might approve based on what they have historically approved.
Sure. Understand.
And but we can, there's a first time for everything.
Right, okay, thank you.
Representative Gray, you're recognized for a question.
Thank you, Mr. Chair, and thank you for going into such detail on this. And you put there could be some small savings to changing. Is there any way that you could just quantify that, guess on that, or is it something that you would recommend us looking into further?
I would recommend looking into it further. I did a really rough back-of-the-envelope calculation that did not include the 3 Rs, reinsurance, risk adjustment, and risk corridors, that set sort of an outer bound of about $2 million a year in state funds on the savings.
That's as much as we're looking into in the whole dental program itself in
But
state funds.
I would recommend doing another level of analysis on that, because those 3 Rs could result, and some other pieces could result in some impacts to that, is very much a back-of-the-envelope calculation.
Okay, thank you.
Would you like us to do that? I just want to make sure.
Yes, go ahead and do that.
Okay. Okay, do you want to continue, Justine?
Oh, hold on, guys, I've got one more question here. Seat 80, Senator Stubblefield, you're recognized for a question.
Thank you, Mr. Chairman. John, concerning these different plans, were there any incentives added to the silver plan to encourage people to sign up on that plan?
And are you asking for the private option or?
Private option, yes.
So for the private option, the only plan structure that was offered was a silver plan.
Okay, let's get off the private option. Concerning all the other plans, the gold, the platinum, were there any incentives given on the silver plan that would encourage people to sign up on the silver plan?
Well, the premium for the silver plan is lower. Premiums for the silver plan are generally lower than premiums for the gold and platinum plans, because it does cover a lower amount of the actuarial value of the plan, leaving a higher amount that is going to be the
Were there cost savings, were there savings accounts or anything like that involved?
Not generally, no. Not through the exchange.
Okay, thank you. Thank you, Mr. Chairman.
I mean, if I could just add, that's one of the big issues we raised in our recommendations, Senator, so that you would have some incentivization moving up the ladder too as well. So, I mean, incentives are important, and it's hopefully something that your governor and the department will be talking to CMS about shortly.
You can continue on.
And this next slide actually largely covers some of the stuff that I just talked through on the previous slide, in terms of the considerations associated with pegging the premium for the private option to different levels. So going on to the next slide, slide 15, asking the question of whether it would be possible to put the premium amount onto a health savings account or a similar account to allow the enrollees to purchase a plan. Having any sort of enrollee awareness of the PO plan prices could put some downward pressure on the rates and create some competition. Whether that would require actually putting the money into an account to have that visibility there is a different question. Generally, the use of any sort of account incurs some sort of fees associated with it, and unless they are then able to keep the balance for some purposes, whether it's health-related expenditures or otherwise, there may not be a benefit to actually putting it in an account, whether the full amount. But if there is an opportunity for them to keep some of the money in some form, then you would need to have some sort of account structure. Any sort of shared savings structure would really need to be carefully constructed to avoid higher costs for the program overall. And this is getting into the idea of having something more like a health savings account, maybe associated with a high deductible plan. If you fully fund health savings accounts across the board above the actuarial level of the premiums, it actually tends to be higher cost than otherwise, because in the aggregate, because most people don't, or a lot of people don't have very high healthcare costs in general. And so you would be putting a bunch of health savings account money into accounts without, in many cases, those expenditures occurring.
Okay. One of the questions that came up from one of the representatives was about the Tennessee Primary Prevention Initiative, and Richard has done some analysis research for you on that.
Representative Orvillo had asked us about the Tennessee Primary Prevention Initiative. We contacted the Department of Health in the state of Tennessee and spoke to several people there, including the administrator of the program. This is an interesting program. It's basically, Tennessee Department of Health considers this basically a health education construction for the general population under a public health framework. It was initiated by the current commissioner in 2012 of the Department of Health, who happens to still be there. It's focused on several key areas that you are all aware of and that we have discussed, and Dr. Ron had presented when he gave the Best in the SEC presentation, and this is sort of related to that. For the Department of Health, this was an effort to increase the population health of the people of Tennessee who have similar outcomes in relationship to general health as Arkansas. It's focused on prevention, health education, tobacco use, obesity, teen pregnancy, infant mortality, substance use abuse, occupational injuries, which was an interesting one that I haven't seen in a public health framework, but an important one, and healthcare associated infections, as well as increased immunizations. The uniqueness of this program is twofold. One, this is entirely generated from the community up. It can be any organization, group of people, faith-based organizations, group of doctors, who come together in their community and work with the Department of Health to generate a program plan. The Department of Health has developed 6 or 7 modules that they call toolkits for these general public health goals, for instance, to decrease obesity and help people manage their weight. They have modules for every one of these. The other interesting, unique aspect of this, besides the grassroots orientation of it, is that there are no resources provided by the Department of Health to these communities in the form of money. So this is generated off of the efforts and investment of people and time in the communities themselves, which really brings it down to initiative in the community. So it tends to have potentially a better impact because there would be communication at the community level across the community rather than down from the state to the community and across the community. The commissioner also instituted something that the employees of the Department of Health seem to like quite a bit. That is, every single employee of the Department of Health, regardless of their job, it could be administrative support, the commissioner, could be an MD that works for them, it could be a janitor, has to spend 5% of their work year in the community on a project. So in talking to Mike Gregory, the administrator, the head of health education, he says, you know, when this first started, they've got a couple of years down the road on this, that, you know, some employees were saying, oh, I don't know how to do this, or they were hesitant to do it. Now it's become a real morale booster, and people in the department are really invested in these projects. They've been pretty robust. The original goal was to get them in all 95 counties. In 2012, that looked like a daunting task, considering the nature of the project coming from the community up. They have achieved that and more than that. They've had 735 projects, 386 have been completed. If you go to their website, if you have deep interest, the Bright Spots tag on the Department of Health website will give you some of the individual programs that they've successfully completed and have been replicated in other counties in the state.
Any questions? The next slide is the lockout provisions. I think was Senator Cooper, it may have been, but one of you had asked about the lockout and impact. So we did some review. In Indiana, there's a power account that they have for 100. They make it mandatory for 100% above, 100% to 138, and you have a stepped up than basic plan, and you'll see as I go through the beneficiaries, I'm going to show you in a minute, that it's called HIP Plus. And then basically, if you, in a nutshell, if you don't make your premium payments on your HIP Plus, you end up going back down to basic, and where you get vision and dental if you make your premium payments. If you don't, you go down to basic, and if you're in the basic and you don't make your premiums and you're from 100 to 138, you can get locked out. The notice will come and you'll have 60-day notice, and then you're given 6-month period where you can't come back onto the program. And so I want you to think about that, because we did recommend some form of lockout as an incentive too here. You can structure it a little different way, because I want you to think about that as we begin to talk, as we tell you about what happened recently in Montana. So I think it's really important, and the governor's office and the department should know about these issues when they go down and negotiate. So it was important for me to find out, all right, is it working? And that's what Senator Cooper wanted to find out. So we went and dug a little more. So Indiana is the first and only state to receive CMS approval for Medicaid expansion plan that includes a lockout policy for non-payment. The current plan was that's derived has been successfully demonstrated since '07, and there's some other outcomes I'll show you. A similar request was made by Pennsylvania a couple years back. It was denied. This was back in a previous administration, I believe, when they started this discussion. And then they amended the power account plan, and they were able to allow them to grandfather. CMS allowed them to grandfather it in. According to the 2012 report, 12% of the members were disenrolled through lockout coverage over the 5-year period. It's important to know, over a 5-year demonstration period. So when I began to ask questions specifically, I was able to get in touch with their actual state consultant that helped them draft the waiver. And they had just submitted the quarterly report to CMS. So the next slide here is giving you information on their quarterly report, which was just submitted. She told me the original time period was 12 months for non-payment, and then they reduced it before the negotiations to 6 months. The payment rate today is 94%. Very high, low impact of beneficiaries. This is, again, they talked about 100%, below 100%, and this is what she had told me in the original waiver program, and they thought that was real effective, from 50 to 100 as well. But they chose to keep it going forward at 100 and above because they provided some other penalties for 50 to 100. And I believe that was where you don't get your vision and dental and some other issues. Michigan recently contacted Indiana to ask them if they could help them through their process, because Michigan is seeing premiums are not being paid at a rate that they would like. So they're working on working with Michigan right now. You will see total enrollees, this is the very quarterly report I was talking about, was just filed with CMS in October. Up above, you'll see at 100% FPL, there are 27,828 enrollees out of 264,000. Very similar numbers to what you have in Arkansas, 10.5%. But the low number of lockout is what I want you to focus on. 848 in the recent report failed to make the power account payments and were locked out. So it's a very low number, again, showing an effective payment rate. And that's Indiana. Need to balance this off. There were a couple other studies we were able to find. There's a 2003 Oregon study, actually Oregon expansion, and there's some recent studies that we reviewed. Oregon's example was a little different. There was a large drop, 46% drop in standard enrollment from March to December compared to a 3% the previous year when they began to put in the lockout period in Oregon. 2003 study reported that 22% of those who left the program cited owing bank premiums. Back premiums. So you have a significant increase in impact there versus what you saw in Indiana. Rhode Island imposed premiums and lockouts on the state's Medicaid program for low-income children, parents, and pregnant women in 2002. Within 3 months, 18% of the families subject to premiums were locked out. So, but these were older time periods, but those, again, were some of the impacts. So, Senator, there's a range of different outcomes here, but I think that Indiana most resembles what we had proposed for this particular task force. So I just think it was important to make sure before you discuss those issues, and I know that incentives are important, and the one thing that the consultant told us in Indiana was the stick is important as well. But the stick applies to the 100% and above, which are folks that are earning some income and are working at lower wage jobs. Any questions?
Senator Ingram, you're recognized for a question.
John, since that program is in place, is there any way to go back and look at the numbers in '07? I mean, I would think that once you establish the program and they realize that you can be locked out, that maybe the first year the numbers might have been extremely high and they've come down over the 8-year period as the participants have learned the program?
Absolutely, Senator, and we'll get those for the next meeting. I'm sure they're available.
Representative Ferguson, you're recognized for a question.
Thank you. Are the premiums, I guess, collected by Medicaid or by the insurance company? And do you have a recommendation in that regard?
The premiums are collected by the Medicaid, state Medicaid. And our recommendation here was obviously to continue to allow those premiums to be paid here at the same way it's paid today, but have the impact of, wellness program, positive incentive, vision, dental, positive incentive, failure to pay, and then the question becomes, the lockout provision we recommended was the same. It was a 60-day notice. It was a 6-month time period, but you could also put a hardship provision in. You could do a lot of things in your waiver to make sure that you take into consideration all of the potential inequality or inequity, whatever you want to do. So they're still subject to some reasonable rule writing, but also 50% to 100% is a population that you could try, but I believe from what we've seen, CMS will not allow that. There is a question in our mind whether CMS will allow Arkansas to do a lockout at all. And they may just say that this was grandfathered, and that's why Indiana is a different example. Remember, Pennsylvania tried this, and they said no to Pennsylvania. But again, it goes back to that issue of negotiating waivers.
Well, and maybe, what about the cost of administering the program, the cost of collecting the fees, educating people about the process? What is the return on investment in terms of cost benefit for charging premiums?
I mean, I asked that question, and the administrative costs are paid for at the high enhanced rate. So and the administrative costs were not high in terms of any type of collection efforts compared to what we had heard that they could be. The consultant we spoke to didn't indicate that was an issue at all. Also indicated that it really incentivized payments. And they did a lot of outreach in Indiana on this issue. So they did talk to the communities about making sure you pay your premiums or there will be consequences. It seemed to work. So, I mean, it seems to work at this point. It's a behavior issue, but you also have an option, I think, in this state to allow for positive enhancements too. And that's why we had recommended where you don't offer vision and dental today, that you think about that.
Well, I mean, it's the same problem we've experienced with the independence accounts. If they owe $5 and they don't have a checking account, what kind of provisions do they make for patients to make those payments?
I mean, they go through that and they educate them up front, and there's numerous opportunities for them to call the State Department. They provide them the notice. The notice has a 60-day time period. The notice describes specifically everything they need to do to make sure they're up in terms of their payment. Back to situation. Again, you could even put some type of hardship provision in there in the waiver discussions if that's where you want to go. But at the end of the day, these are individuals that are getting a benefit that the state is giving them, and the state is asking. Remember, the premium payment is up to 2%, so it's up to 2% of that family income. So, and it can't go beyond that, and CMS hasn't allowed that. And the total cost share as well, combine the cost share with the premium, cannot exceed 5%, cannot, of the income.
I guess what I'm asking is the amount of money they collected on premiums equal to the amount of money they spent on administrative cost.
I can ask that specific question.
Okay, thank you.
All right, so what we're going to do is we're going to have lunch at about 11:30. We've got enough questions that should take us at least to 11:30. The next one on the list is Senator Ervin.
Thank you. Along those lines, and Senator Ingram, what he was saying, and you just mentioned it's a behavior issue and learning how to use the system. If we're looking at really constructing a system where it's a ladder of opportunity, where we want people to transition out of this up into above 138 to 400% federal poverty level, they're going to have to pay a premium. We don't want people to stay in this issue. And so, to me, I think we're missing the point in that it's a process of education on how to use a system which is now mandated that you have to have insurance. So it's teaching them what premiums are, how to shop, how to understand what their benefit is. I mean, I just feel like we're missing the point on the value of this type of a lockout type structure. Does that make sense? Could you elaborate on that? Because if Senator Ingram is right that the numbers went down and they have a high compliance rate, they were successful in teaching folks that if you pay your premiums, if you don't pay your premiums, there's a consequence. If you do pay your premiums, there's a consequence that's positive. Does that make sense?
It absolutely makes sense. I mean, it's in our recommendations.
Yeah,
In our
I know.
recommendations, we specifically highlighted what you said, so that when they're at 139, and they start going for either subsidies or employer-sponsored, or even if they have employer-sponsored and there's a premium, that they are beginning to get the feel and condition and understanding of paying for health care.
I just think we need to emphasize that more. Thank you. I appreciate it.
So, moving on to the Montana waiver, if we don't have any other questions?
No, we do. We've got questions. So here, my expectation is we're going to take questions till 11:30, then we're going to break for lunch till 1. I've got 3 more questions, so hopefully we can get those in and finish that by 11:30. Senator Cooper, you're recognized for a question.
So basically, when you started investigating this further after the question that we raised on that, the premise of your original recommendation really has not changed, even though the fact still remains that it may or may not be approved as we asked for it. It's just been refined a little bit. Is that?
Yes, and I would like to get into the Montana plan, because it's
Thank
consistent with this, and I don't know if we're going to be able, if we can just finish that before you leave, so you have that in your mind. But it's up to the
Yeah,
chairman.
we'll do the Montana afterwards. We've
Okay.
got 2 more questions. We're going to leave here at 11:30, and then we'll be back at 1.
Okay.
So after Senator Cooper, Senator Chesterfield, you're recognized for a question.
Thank you, Mr. Chair. In the Indiana plan with the lockout, were there provisions for emergency care?
Yes, yes.
And then secondly, and I'm moving right on along, I'm looking at page 22, Oregon, 46% drop in OHP standard enrollment. Was that supposed to be a good thing? The enrollment dropped from 104,000 in January '03 to 49,000 in December. Was that a good or a bad thing? Or we're losing folks, or
Well,
because of the lockout, or what?
It's fact, so I just wanted to make sure you saw that. I think many people would think it's not a good thing, and others would think it's a good thing, depending upon what you want, because maybe you're again, it's all about these folks that are not being incentivized to participate. It's about participation. And you really gotta have a way of identifying what's gonna bring them to the table to participate, to have better outcomes, to have, better, at least make sure that you're at the right settings. And again, paying your premiums are part of that, Senator. So, but again, I want to make sure that you see all the facts here so that you can make your decision. But I will tell you that that is a significant drop.
Yes, it is. Thank you.
And that was pre-Medicaid expansion.
Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. You predicting that CMS will not allow the blockout on the basis of having rejected another state's application for that. What was did you find out anything as to what they were using to justify the reason to deny that state? Was it because they didn't have ulterior plans, how to deal with that population? What were some of the reasons that CMS stated?
Unless you actually can speak to someone who was in the middle of that negotiation, I can't get that information. I can try to. But I can tell you, based on what I know from talking with the state of Indiana, speaking to a number of others in the community that are currently looking at waivers, and what the state of Montana recently was approved, I think it's fair to say that they're going to have questions on the lockout if you move forward. But it is absolutely part of our recommendation. We believe it should be part of that discussion.
I guess my point is that it would be nice to know, it'd be nice for us to know what their reasons for saying no were, so that if we're going to include that in our, request to CMS, we could address those issues so it would minimize their ability to say no.
It's a good question. I can try to find out. And I just want you all to know that it doesn't mean they're going to say no. They could say yes to Arkansas.
Okay. All right. Thank you.
Great job, Task Force. We exceeded Senator Chesterfield's expectations in terms of the speed of the questions and answers. And so we're going to break for lunch, and then we'll come back at 1 o'clock. And John, you guys can pick up with the Montana expansion waiver at that time.